I'm going to talk about cholestasis in the premature liver today because it is a completely different beast than cholestasis in a term infant, and I wanted to discuss the differences. So, why is liver disease in the NICU different, and how should we evaluate it? I think the things you need to think about is, why is the premature at risk for liver dysfunction? Does gestational age matter? What about the comorbidities that the babies have? And how does prematurity change the impact of genetic mutations? And then finally, what do we actually see in the NICU? So, transporters are different in the premature liver because they're developmentally regulated. And in the premature, you don't have nearly as many transporters for bile acids. You don't make many bile acids. You don't have much FIC1, which allows the membrane between the hepatocyte and the bile duct to be normal so that the transporters can embed. And then you also don't have much of the main bile acid transport protein, which is called BSEP, or bile salt export protein. So in general, you don't have much synthesis or transport of bile acids in the premature liver. You also don't have much uptake of bile acids from the blood once they've gone to the gut and been reabsorbed. So everything is downregulated in the premature liver. There are also differences in transporters of bilirubin. So bilirubin comes from heme. Babies are born with high hemoglobins that rapidly fall because they don't need a hemoglobin of 20 when they are born, and all that heme needs to be processed and then conjugated in the liver and transported out. And in the premature liver, you have a high amount of heme, but you have very little of the transport protein to get that conjugated bili out. And so you can overwhelm the system, and you may have conjugated bilirubin, but since it can't be transported out, it rises in the serum. You also don't have bile ducts in the premature liver. You don't get the number of bile ducts until about 42 weeks gestation. And so if you don't have any bile ducts, it's really hard to transport bilirubin and bile acids. And on the left, you see a portal vein and hepatic artery, but no bile duct. And then on the right, you can see a normal portal tract, which has veins, arteries, and bile ducts. So in the premature, you have decreased bile acid synthesis, decreased transport, you have decreased bilirubin transport, but an increased load. You have a paucity of bile ducts, and the bile acids that you actually make tend to be more toxic and cause cholestasis themselves. So this is a perfect storm for a situation that's going to give you cholestasis. Then you have comorbidities. Bad things happen to babies in the NICU, especially urinary tract infections and sepsis. And this is a study that I did that looked at about 160 babies, and a number of them had urinary tract infections and sepsis, which accounted for their cholestasis. So in sepsis, you have even more downregulation of bile acid synthesis and transport. You have more downregulation of the transporter for bilirubin, and you have downregulation of bile acid transport. So again, the perfect storm just turned to a hurricane. You also have problems with thyroid and adrenal hormones, which are important in cholestasis. And this is probably because of membrane issues, but if you look at our study in the NICU, 24 out of 160 had hypothyroidism as part of their reason for cholestasis. They also have an increased load. They may have hemorrhage into the brain, the lung, or the abdomen, and have even more to transport at a time when they don't have very much transporter. And in our study, 24 of the 160 babies had issues because of an increased heme load. They also don't have the best blood supply. Most of the liver is supplied by the portal vein, and it is very sensitive to shock and ischemia. And if you looked at our study, a fair number of them had cardiac disease or shock as one of the contributors to their liver dysfunction. They also can have vascular abnormalities. In our study, 12 had intrahepatic shunts. 6 of those were patent ductus venosus that closed, but 6 of them were abnormalities from embryology of the portal vein called Abernathy shunts. These are more common with cardiac disease, but don't have to have cardiac disease. And what's the role of genetics? So genetics mutations are described for bile acid synthesis defects, for transporters that help modulate bile composition. We have mutations for ductal plate malformations and many of the metabolic processes, and for bile duct formation in things like Alagille's and Paucides syndromes. Most of the mutations that we're talking about require 2 abnormal mutations, like in bile acid synthesis defects, but we have a fair number of transport defects where disease has been described when you only have 1 known mutation. We also know that multiple mutations are more common in babies with cholestasis, and those are multiple heterozygote mutations. And there seems to be a suggestion that the interaction between deficiencies of transporters may be important, where having just 1 mutation may not be. There's lots of problems with genetic data. One of the problems is that my grandson is going to have a very different set of genetic mutations than somebody that was from Africa. We know in Northern Africa, the mutations for bile acid transporters are much more common and may be different than those in Northern European Caucasians. And we need to take that into account because our databases may only have the Northern European mutations listed. We're also rapidly finding new disease-causing variants. This is a baby that was a twin. His twin did fine. He had no risk factors that should have given him cholestasis. He did have infection. He did really pretty well, but he definitely had cholestasis. He had mutations for CFTR, a mild mutation for alpha-1, and 2 other VOUSs. And as a preemie, he just didn't grow well until a couple of months after term, and he just took off. We don't know if this had anything to do with his transporters, but transporters are normally low in preemies. And so if you say have a mutation that gives you half activity, you may not do well when you have low levels of the transporter, but as you get older, may do better. And this is something we relatively commonly see. And this baby is now growing exceedingly well and doing well and has no signs of liver disease. So we do see lots of infections. We see lots of UTIs. We need to think about CMV, not only congenital, but one of the tidbits I wanted to point out was that in premature infants, CMV can be acquired through expressed breast milk. We also have a lot of genetic mutations. If you look at my study, we had 12 babies with trisomy 21, which can cause cholestasis, and then a whole host of other mutations which were associated with liver dysfunction. If you look at our overall study, many babies had multiple causes, but infection, whether it be UTI or sepsis, were the most common, followed by shock, genetic abnormalities, translocation, which is sort of like infection from neck, and cardiac disease. And the common things that we see in older infants, like biliary atresia or cystic fibrosis, were actually exceedingly uncommon. This liver disease is significant. This is a pie chart of what happened to all the babies in my study. You can see about half of them resolved their liver disease by the first year of life, but a fair amount went on to having continued disease. And the red slices are babies that died from liver disease, or liver disease was a major comorbidity in their cause of death. So liver disease doesn't always go away as soon as they reach term. Ultrasound was very helpful in managing these babies, and a significantly larger number of babies had abnormal ultrasound reports. Doppler was also very helpful in helping us look at liver blood flow caused by cardiac dysfunction and helping as a team approach decide when cardiac interventions needed to be done. So when you're looking at a baby with liver dysfunction in the NICU, what do you think about? Because you can't just use the term baby cholestasis guidelines, and also they don't have very much blood. So you have to be really careful about what you ask for. I think you need to ask how sick is the baby, what else is going on, what's the pattern of abnormalities, and can I get this information any other way, either with imaging or with urine studies, but you try to get the most bang for your buck. I always tell my fellows that they get 1 to 2 cc's a week to monitor these babies. That's not very much. You have to be really careful. So red flags in that this may be something we really need to go after would be hepatosplenomegaly at birth. So that would indicate maybe viral disease, a storage disease, a bad metabolic or heme disease. So that's a red flag. Certainly a coagulopathy with direct bilirubin but low transaminases may indicate GALD or something that has a very low liver mass. And then prior neonatal deaths always make us really worry about genetic liver disease, and again, GALD is on that list. So what things are more likely in the premature infant? Prenatal insults, viral, genetic, placental, maternal illness. Certainly complications of delivery can give shock and liver disease that should get better with supportive care. A large heme load is important. Non-hepatic infections are often a cause. We look for vascular malformations and then other comorbidities. So what do I usually ask for? In a well-appearing premature infant that I have a little bit of time, I always check the newborn screen, make sure that there's nothing there. A urine culture, since UTI was the most common cause of dysfunction we found. We look for thyroid disease. This isn't necessarily picked up on the newborn screen, and prematures are at significant risk for thyroid disease. Maybe coagulation studies, they are very hard to get in a premature. They require a larger volume of blood that all needs to be in one good flowing stick. So if we need them, we get them, but we sometimes wait. I always ask for an ultrasound with Doppler because congenital malformations or blood vessel flow issues are common, and these babies tolerate ultrasound well. I consider genetic studies early in the course. You need to get them before you transfuse the baby, and they take a while to come back, but you get a lot of information for a little bit of blood. Sometimes we get urine bile acids looking for synthetic defects. And if we're trying to figure out if the cholestasis has resolved when the babies are older, because the bili is now normal, and I think it hasn't, so they still need formula manipulations or vitamins, I may get serum bile acids. But in the very small preterm infant, they're often not helpful because of lack of synthesis. In the sick preterm, I think of this as the liver evaluation and the systemic evaluation, and they both go on at the same time. And here's a list of studies that we think about. These babies are often extremely sick and we need an answer right away, and so we're very aggressive at looking for things. I also think about, is there a treatable cause? So GALD, or gestational alloimmune liver disease, is very treatable, and you need to treat it quickly if you're going to save this baby. So I think about that. Viral infections, especially herpes, are also treatable. Some of the metabolic defects, amino acid or organic acids, are treatable. Mitochondrial disease isn't really treatable, but supportive care can really help. So I think that's on the list of things that you want to go after. If something isn't fixable, even though it may be important, you may wait a little bit to diagnose it just because you have to prioritize your blood draws. So liver disease, it's really common in the premature infant, and it's very complex. And I think you need to remember to understand the pathophysiology of the preterm, and that will help you guide the evaluation of their liver dysfunction. Thank you.